Hi everybody, thanks for the introduction. Yeah, I'm going to give us a talk on ethical approval de-identified clinical data in routine using the routine data. And essentially, the problem is that we have a lot of data, a lot of information stored in archived, which isn't fully utilized. So we don't make maximal use of the data, and there's a lot of processes which make it difficult to utilize the data we've got and make most of it. And I think one problem that we've come across, one thing that I'll try to talk about in this talk is the ethical approval process, where you have an applicant who applies to do a study, and there's a process involved, and there's getting review and then getting it approved. And you might have multiple people in individual hospital all applying to the same body for slightly different projects, which are all potentially at the same processes, the same, they need to kind of the same main steps involved, but the actual research will be slightly different. So there's a process there which is quite tricky, and it can be a lengthy process. And I think just, some people, it just puts them off, and some, particularly clinicians who are busy, who might want to do a project, they just don't have the time to go through these processes. And so I'll talk a little bit about how in Sheffield we've done that. And I imagine other people will have similar, potentially, or different approaches to their institutes. There's another talk on pseudonymization and anonymization. So I'll just very briefly say this is kind of very central to the issues. How do you use the data for research and do it safe and so protect the patients? Anonymization, clearly that's the best. If you can just fully anonymize the data, then the key is lost and that information is not identifiable, and it can be used for research. But there are some limitations in terms of the flexibility of that and what you can do with data. The other approach, which within GDPR is recognised, is pseudonymization, but it's very important that the key information, the link information, is kept separately, and it states there are technical and organisational measures that keep the other data away, so that the research team does not have access to that data. There's a section 251 in the NHS 2006 Act, which where you can get approval to use consented data, personal data. You can get approval to use it, but this wouldn't be required if you have data that is fully anonymized or is pseudo-anonymized, and with these technical and organizational measures in place to make sure that is the case. So there is also, you may be aware, there's a national opt-out scheme, which I've been quite surprised how many patients have opted out, more than you would actually first think. Some people maybe weren't even aware of it, but actually patients do opt out. They do see it and they do opt out, and it is live. And you can, so for instance, we can contact our hospital and get a list of patients for each study, for each data extraction, and we can make sure that those patients have been opted out. So just a bit about the Sheffield 3D lab. So we've got to talk later on a bit more in detail about this, but it's an organisation which was primarily around the medical physicists and radiographers, but also involves the radiologists. And the idea is to improve imaging assessments, improve the imaging processing, also surgical planning, and 3D models and even 3D printing. But I didn't really want to talk specifically about the 3D lab, more the process for how we've organized data. So we have an ethical framework that covers the imaging through the 3D lab, which covers the imaging in our hospitals. And there's various steps. So I'm going to go through these steps now as to how we do that process. So we can identify patients based off the inclusion criteria, give them a unique ID, and that's the responsibility of the STH computing and medical physics team. We have an access form that the researchers will complete, and it will be sent to a database management committee, which includes like a scientific committee, and also there's a lay component to that as well. So the review, then the request is reviewed with process to review the information submitted, and then if it's approved, then the data can be acquired from the clinical records by the medical physics team or the clinical care team. But we have a study coordinator who tracks the studies, and also we have to have an assigned data manager to each of these studies, so we know a person is responsible for the anonymization and the extraction. Whenever we do an extraction, we have to do check the opt-out. So you have to check the opt-out for any fresh extraction and remove those patients. And then once that's done, that's the data is then de-identified, and with the unique code retained, the data is inputted into a spreadsheet or repository, and this all occurs within the firewall of the hospital systems. And then the de-identified data can then be sent to the requester in the university, where from their point of view, the data is anonymized, though it's anonymized because we still have the links managed by the data manager. So just to go into detail on what it looks like, this is the form. We have a form where you have to fill in the title, the nature of the study. There's another sheet I can form as well. So it's relatively short, but it's not like a full IRAS application you have to go through to get the approval. And the data management team will review the application and will look for various criteria, and also a lay member has a separate form actually for review. And then and then there's an outcome to the process, and then certain requirements that the researcher has in order to use the data appropriately. Then there's another thing today on XNAP. So we use XNAP in Sheffield, and I think it is an excellent place to store data. There's a data repository allowing you to have subfolders to store the individual studies, and you can then potentially do specific downloads from that, within it, or specific. There's ways of downloading particular images or particular studies within that, so you can go into look at the individual studies and then get the kind of the sequences, whatever that you want, and I think it's just a good system. And this process has allowed us to develop multiple algorithms, which have working with various members of the university and the medical physics team. One of which, the kind of segmentation, we have implemented in our hospital, because it's trained in our data, so it works better than something that hasn't been trained in our data. So that works process that works very well for us. But this is just Sheffield, and I think it's nice to think about how such a process. I mean, someone's probably going to tell me this already exists, aren't they? But some process where it can handle the diversity. So something, for instance, so we all know that algorithms trained somewhere with some demographics. If it's trained in Oxford, is it going to work in Barnsley, for instance? That kind of thing. Something that's then there's the questions: either do you centralize the actual imaging data, or do you do more federated learning? I think there's some companies I think potentially creeping in. I don't know how the involvement, exactly what will happen, but I think that, and then there's the sort of secure research frameworks, are the secure research environments which could be used. So I think this is a bit of a debate as to how you do it. I mean, I think there is a potential to apply something similar to this and create a national database, which is. And I was just chatting earlier that the big problem, isn't it, with AI development, is individual hospital is going to want to trial the new AI softwares that are coming, and that's going to create a lot of work across the country. So could it scale nationally? Well, when we talk to patients, they are really keen that AI is used in the appropriate way, and they want their data to be used appropriately for research purposes, provided it's done in the right way. I could see a national kind of scale approach like this, where we don't have to be submitting ethics applications, provided the process is similar. If you had something like this, the priorities could be defined by, you know, whichever higher power, NHR, RCR, or, you know, whoever by NICE. The lay panel could be a national, and that would be a national panel with lay people. Then how it actually worked would be the challenge, and how hospitals would be invited, and then you'd have to set up processes where data could either be shared, or you use the federated approach. I do like the idea of a national DICOM retrospective database. That doesn't already exist. And then, yeah, researchers can then apply in a similar fashion with their particular project to utilize the data, or prioritize studies could have a could be prioritized based on the sort of national objectives. And that's me. Oh yeah, sorry. So just the advantages, I think that could potentially facilitate more research to be done, targeted to specific problems that we face in terms of AI development. And the challenges are always, you know, the data, funding, time for individual hospitals, isn't it? And that's just to thank the people who've been involved in this work, patients, a lot of work in the data and infrastructure. That's probably where the biggest time goes. The image analysis, expertise, and the clinicians supporting the radiologists supporting the work. Thank you very much.